we use a malleable retractor, try to just put the fat inferiorly. And then we use the retractor to track the medial canvas and caruncle medially. Hold 住呢個，And then we use a pair of a blunt tip scissors to feel the posterior lacrimal crest. And then once we feel the lacrimal crest, we spread the scissors. This is the medial orbital wall. Of course, we can incise the periosteum if we are doing the medial orbital decompression. This is a cutting of the periosteum. Then we can use a freer periosteal elevator to do the subperiosteal dissection. Freer喺邊度？揾到。So now, can you see the medial wall? In fact, through this medial wall, you can see the anterior and posterior ethmoidal vessel nicely. If you want to enhance your visualization, you can put your endoscope inside. 有冇個細少少嘅 malleable?
So for all these approaches demonstrated, the beginning we don't need to use.
No. At the first part, no. But then after we make the incision, when we go deep inside, I think using endoscope is nice. So this is what we have just discussed yesterday. Endoscopic transorbital surgery. Previously, what we do is that we use our naked eye. And the first part is nice. But when we go really deep inside, we can't see clearly. So now when we work with Kelvin, after we make the periosteal incision or periocular incision, we find the anterior aspect of the mask. For those very sticky ones, we put the endoscope in and use the endoscopic guided dissection. Yesterday, we demonstrated, we saw the ophthalmic artery, we saw the cranial nerves, and then once we can see that, and then it's much easier for us to preserve all these important structures, leading to a better optimal outcome. So that's all I want to say. Are there any questions for me? Last but not least, let me demonstrate the reverse swing eyelid approach.
4 approaches demonstrated: decrease, the conjunctival, and
the reverse swing eyelid is particularly useful for supromedially located lesion. In fact, we did several cases. So basically, it's the same. So we did the canphotomy, and now we did the superior canpholysis. So once we cut the superior canpholigament, you can put the eyelid supromedially. So now the next incision is over the fornix. And the fornix is posterior to the levator. Because we are posterior to the levator, and this incision will not cause ptosis. Now, basically, just make it here, and then a blunt dissection, and then you can go into the orbit. And then for supromedially located orbit, we can put the endoscope inside this small incision to dissect the lesion out. So bear in mind that the supromedial part is difficult because of the supraorbital neurovascular bundle, as well as the trachea and the superior oblique muscle. So I think if you are operating on that area, I think better to get an ophthalmologist with you. Yeah. So much so for the periocular incision. So this is just the start of the transorbital. So I think if you have no question, maybe you can go to your table to try. Okay. Pardon me?
What sutures do you use?
Okay. Yeah, if this is a transcarancular incision, just 1, 2, 3, 6 cervical, very easy. Transconjunctival incision, the beauty is that actually you don't need to close it. But I personally just like to approximate the superficial conjunctiva. So say, for example, for the inferior transconjunctiva, I close with maybe 3, 1, 2, 3, and then close the lateral canvas. In fact, you put everything just in position, it will heal nicely. Yes. Yes. And if you want to remove that, it's fine. If you don't remove it, it will just fall by itself. I think it's fine. Pardon me? Post-operative is, I think, most importantly is to check the vision before surgery and check the vision after surgery. Make sure there is no retrobulbar hemorrhage. I think if there is a very proptotic swollen, vision drops, I think this is an emergency. If vision is okay, pupil normal, we check the eye pressure, everything, we just put the patient some topical steroid antibiotic eye drops and topical steroid antibiotic ointment to the skin wound. And then everything will be healed nicely. If for the transcutaneous wound, usually I remove the suture at 1 week time. And then we seldom have a wound problem. Because it's a dual layer closure, we close the orbicularis muscle and then the skin don't have much tension. So much so for the periocular incision.
Thank you. So, okay, so let's divide into groups. Okay, now the first part, I think, well, all of us are either neurosurgeons or surgeons. So probably this is the first time that you've ever done these kind of different orbital approaches if you haven't attended other orbital related or transorbital courses before. So for the positioning, that's a good question. You stand at or sit at the top of the head of the patient first, okay? You're divided into 5 groups. So you might not want to fix the head first in the main view, okay? Just do the incision first, the 4 incisions. Professor Yun will be around to guide you. If you have any problems, questions, so he will show you how to do it, okay? And then let's work on it for around an hour, okay? And to see how far you goes. But of course, the main dish would be the afterwards. So we'll put an endoscope, okay?